Chairman, dear colleagues, first of all, I would like to thank you for the opportunity to be here and present our data on behalf of study investigator. I'm going to talk about ablation of newly discovered paroxysmal atrial fibrillation during CABG surgery. According to the US population, the number of persons with atrial fibrillation is projected to be 12.1 million by 2050, assuming no adjusting increase in incidence of atrial fibrillation, but 15.9 million if the increase of incidence continue. From the other hand, we have some studies concerning the progression of paroxysmal to persistent atrial fibrillation. And in this particular study, which you see from the left side of the slide, were included 1,200 patients which were followed up during 12 months, and 15% of them developed persistent atrial fibrillation, and it was associated with a major cardiovascular events compared with the patient who had no progression of atrial fibrillation. Also, there are a lot of studies concerning the impact of atrial fibrillation on mortality after CABG surgery. And we know that the preoperative and postoperative atrial fibrillation is associated with a long and short-term mortality. And you can see the data from meta-analysis which are summarized in this slide. So the aim of our study was to compare the patients with the first detected paroxysmal atrial fibrillation submitted to the CABG surgery and treated with or without pulmonary vein isolation. And the primary endpoint was AF-free survival between two groups. And the secondary endpoints were percentage of AF burden detected through implantable loop recorder, thromboembolic events, and procedural complications. In our study, we used the following definition of the first diagnosed paroxysmal atrial fibrillation as documented AF episode more than 1 hour in duration with a 2 or more episode over 4 months with ECG documentation at least of the 1 episode. The inclusion criteria were the following: the first diagnosed paroxysmal atrial fibrillation and indication for CABG surgery according guidelines. The exclusion criteria were previous treatment with 1C or class 3 antiarrhythmic drugs, previous heart surgery, and AF ablation requiring concomitant valve surgery, left ventricle injection fraction less than 35%, and left atrial diameter more than 55 millimeters. So in our study, we included 35 patients with ischemic heart disease and first diagnosed paroxysmal atrial fibrillation, who were randomized into 2 groups to receive CABG only and CABG plus pulmonary vein isolation. And we performed the data collection through the 8 months of the follow-up. In our study, we use implantable loop recorder to assessment the success of the operation, and with this device, the arrhythmia detection is made through the analysis of bit-to-bit viability of the cardiac cycle on a 2 minutes ECG, and we can calculate the amount of AF burden per day and AF burden of the overall follow-up period. And in this study, we use the following definition of responders. Responders were the patients who had atrial fibrillation less than 0.5%, and non-responders were the patients who had atrial fibrillation more than 0.5%. And this cutoff corresponds to maximum cumulative time in atrial fibrillation of 3.6 hours in 1 month. It means that in 99.5% of the time, patients were in sinus rhythm. You can see here the baseline characteristic of the patients of both groups, and you can see that the mean left atrial diameter was 45 millimeters in CABG plus PV group compared with 46 millimeters in CABG only group. We perform pulmonary vein isolation with bipolar radiofrequency, and in the end of the procedure, we perform implantation of the loop recorder. What about the procedural data? You can see here that there were no statistical difference between the number of conduits, aorta cross-clamping, and CBP time in patient of both group. Ablation time in CABG plus PVR group required only 3.2 minutes, and the number of application was 2.9 and 3.1 to the left and right pulmonary vein, respectively, and the conduction block was achieved in all patients. All the patients were discharged in sinus-free and free from antiarrhythmic drugs. No patients were excluded from the study, and each patient were followed up during 1, 3, 6, 9, and 12, 18 months after the surgery. And there were no thromboembolic events during 18 months of the follow-up. What about the freedom from atrial fibrillation? And CABG plus PVR group, almost 89% of the patients were AF-free. It means that they had AF burden less than 0.5%, and only 47% of the patients in CABG group were AF-free. And this data was statistically significant. Also, in the CABG group only, the percentage of AF burden was 7.9% compared with 9.6% in CABG plus PVR group. And also, interesting finding that 18% of the patients with AF recurrence were completely asymptomatic. So in conclusion, Mr. Chairman, dear colleagues, patient with recent onset of atrial fibrillation submitted to the CABG surgery may benefit to concomitant ablation of arrhythmia for prevention recurrences. Thank you for your attention.